Andrea, I didn't quite finish my story of how I met her with the Greek hurricane, Angela Melis. So no one sat at the table, and I had to sit at the table, and had a fantastic time meeting Andrea and her husband, Paolo, and Angela and her husband. And Angela leans over partway through and says, "John, you have to have her as your fellow." And I'd never had a fellow. So I said, well, okay, because people don't say no to Angela. And I had a fantastic time meeting Andrea, and that was in 2006, and she's just been an incredible leader since that time. Andrea is recognized for her leadership in the first Canadian guidelines around opioids. And when you say Canada, and you say opioids, and you say guidelines, that's an incredible feat. She did that through lots of work with this national committee that sort of said, this is what we need to do. And guidelines are wonderful. And then you get them, and then they go sit on a shelf and gather dust, and no one ever looks at them. So her pragmatic side to her said, how am I going to do this? And she came up with this little sheet of paper that takes all of the 24 recommendations in the guidelines and puts it on one sheet and puts it in a structured fashion so that me as a clinician, I can actually now effectively manage and standardize the care. She made it into an app. She developed a book for patients to understand this, so not just the physician. She's been leading opioid management for the last really 10 years. So it's a testament to her perseverance, just like it's a testament to Dinesh's perseverance to look at those 18,000 slides of counting. I cannot imagine that. To look at all the journals, to understand opioids, to give recommendations that can be stand out in our country for guiding us is an incredible feat. So please welcome Andrea Furlan here.
Much. Thank you. Yeah, is it working? Yeah? Good, thank you, John, and thank you for allowing me to talk about my passion about helping people with chronic pain, helping physicians to do what is right. I think because I'm passionate, people like to hear what I say, so I think they invited me. I have been on the news, this is just in 2017, from coast to coast, internationally, talking about chronic pain. And my last one was November 3rd. Dr. Brian Goldman, who is an emergency physician at Mount Sinai, invited me because a patient, Kirk Fote, who is here this morning, I invited him yesterday. Kirk, can you stand up, please? Kirk told his story at the White Coat Black Art Show, and Brian invited me to talk about it, how difficult it was for Kirk to come off of his opioids, that he was prescribed for legitimate reasons. He tells his story. Unfortunately, Kirk, you can't tell your story here today. We don't have time, but you can go on the podcast, on the website, and hear his story. He had a legitimate pain, an accident that happened, and 8 years on opioids, hard to come off, and he did on himself. And when he heard about the book that I wrote, The My Opioid Manager, which is on each table, you have this. The book can be downloaded for free on our website, but if you want to have a hard copy, I printed some, and it's for a price of $20. But Kirk heard about the My Opioid Manager, and he said to me, Andrea, if I knew about this when I was coming off of the opioids, it was so hard for me. Why my doctor couldn't help me to have less suffering when I was coming off of the opioids. And that's what we're trying to do. We're trying to teach doctors. The doctor didn't know because the knowledge didn't get to her. So that's what we are trying to do. We are trying to move the knowledge where the knowledge needs to be instead of moving people. Moving patients is expensive. Bringing experts to talk about things at conferences doesn't work. We need to move the knowledge. So what are opioids? You will probably, what you hear today in this one slide, probably you will know a lot more than many patients know this in the streets. Many patients are using opioids and they don't know what is on this slide. Some people don't know that Tylenol 3 is an opioid. Tylenol 3 has codeine. Codeine is metabolized to morphine in your body. Tramadol is also metabolized to a potent opioid in your body. OxyContin, fentanyl patches, all of these are opioids. So opioids are the most potent analgesics that we know. They really are very good for pain, especially for acute pain, especially for these kinds of pain, the post-surgical pain. If anyone has a colonoscopy, you don't want to feel pain, so they will give you some fentanyl or fentanyl for fractures, for cancer pain, for palliative care. But what about for chronic non-cancer pain? That's what we are talking here today. What about the chronic low back pain, arthritis, nerve pain? These are pains that will last years. And myofascial pain, they last months and years. These are chronic non-cancer pain, and that's where we are getting trouble, because a lot of people that have chronic non-cancer pain are put on opioids. The adverse effects of opioids are usually nausea, vomiting, constipation, causes sleepiness. Some people get confusion when they are on opioids, and it's hard for them to drive, to work, and some people get euphoric, which is also dangerous. But I think what you hear in the news is about the risks. There is a high risk of overdose, not only fatal overdose, but non-fatal. A lot of people don't know that they may have a non-fatal overdose. They may overdose, be having a sleep problem for a couple of minutes, have brain anoxia, and be left with an acquired brain injury because of a non-fatal overdose. Addiction is another very common problem. What about people who are driving and working, operating heavy machinery? Are they impaired? And some complications. Some people don't even know that opioids cause sleep apnea. They lower the sex hormones, so people that have low testosterone, they have impotence, because one of the symptoms of low testosterone is fatigue all the time. So they start taking these medications. The pain is better, but they feel fatigued all the time. They don't know why. The sex hormones are down the drain. Hyperalgesia, which is the phenomenon that John explained in the slide before, the central sensitization. Remember that? The slide that John, he said you were going to be tested. This is the test. Hyperalgesia, I don't know if you remember one of those receptors that John showed. Of course you don't. One of those receptors that John showed in the central sensitization is called NMDA receptor. When the body is central sensitized, there is a receptor that opens up. It's called NMDA receptor. Opioids activate those receptors. And guess what? Now opioids are causing more pain. It's called opioid-induced hyperalgesia. And a new thing that has been described in a couple of years, immunosuppression. People on opioids long-term, they have more infections because their immune system is impaired. So here, a lot of things that patients don't know that when they're taking. And that's why we think education is key. Because I have patients that they tell me, Dr. Furlan, if I knew that opioids cause this or that or that, I would have said no to my doctor when he offered me the first prescription. I did not know. Nobody told me about this. So there's a lack of informed consent. People are getting opioids without being informed. What are the risks? We need to change that. Opioids in Ontario. So let's talk a little bit about the news, what's always in the news. I don't know if you know, but 1 in 7 people in Ontario got a prescription of opioids in 2015. 1 in 7. We are a province of almost 14 million people, and in 2015, there were 2 million people got one prescription, and there were a total of 9 million prescriptions of opioids in 2015. A lot of people. Where are these medications going? Some people are taking them, some people are stockpiling them, some people are selling them, some people are giving them to their neighbors, to their friends, to their children, grandchildren. Where are they ending up? The problem is big. When we talk about the opioid crisis, we talk about the deaths, this number here. In 1 year in Ontario, there were 638 deaths. But nobody talks about for each person that died, there were many others who had an anoxic brain injury because they were on an overdose. They ended up in emergency, but they didn't die. And the number of people who are getting addicted and looking at methadone clinics is huge. Methadone is used to treat opioid addiction. Every year, 42,000 people are on methadone programs. When we put this in perspective, we all remember the SARS crisis in 2003. SARS, we had 251 cases in Ontario and 44 deaths. And that's why we have an opioid crisis. It's much bigger than the SARS crisis. North Bay is one of the epicenters in Canada of babies born from mothers who are using opioids, and they have to go to a neonatal intensive care unit because they're born dependent on opioids. Here is a map of Ontario, so divided by regions, northwest, northeast. The number here is scary because for every 1,000 births, 50 babies in Northwest Ontario have to be admitted to NICU. What about our children, grandchildren? What are they using in grades 7 to 12? So when you see here, opioids for non-medical purposes, these kids, 10% of kids in grades 7 to 12, that includes my children. I showed this table to my kids. I have a son in grade 11 and a daughter in grade 8. I showed this to them, and they said, well, yeah, I think I could find some friends that know where to get opioids. They know the opioid manager by heart. They know opioids, everything, because mom talks to them every day. Opioids is now the number 6, where they're getting things for fun, just to get high. The drugs of choice now, opioids, are becoming popular among our teenagers. How Health Canada defines an opioid crisis? Well, they define an opioid crisis. You can find this on the Health Canada, Government of Canada website. An opioid crisis is because there are too many opioid prescriptions and an increasingly toxic illegal drugs coming from powerful illegal substances such as fentanyl, blah, 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 blah. I think this is very simplistic. The opioid crisis is not just because there are too many prescriptions or because there is illegal fentanyl. I think there are many other drivers. There was a strong marketing campaign. There's a social culture. We are a culture addicted to quick fixes, and opioids is a quick fix. Who wants to do 30 minutes of exercise 3 times a day instead of taking 2 minutes, you take a pill, and you don't have to do the exercises? We also can't tolerate any pain. My patients, they come here, I ask them, what do you want from this consult? And they say, I want elimination of my pain. I say, I'm sorry, you came to the wrong place. This is a pain clinic, but I think you we have to come to terms. You have to tolerate some pain. I can help you to reduce some of your pain, and usually the myofascial pain syndrome is where we can help them a lot. They have multiple pains. They have the osteoarthritis pain, they have the rheumatoid arthritis pain, and they have the myofascial pain. I say, I can help you with the myofascial pain. Maybe the other ones, I can't do a transplant of your spine and remove all the osteoarthritis that you have in your spine. But the myofascial is one that I can help. So, but patients have a wrong expectation. They want all of their pains removed. Or they have a lot of psychosocial problems. And the medical service that doesn't help physicians. We are paid by the number of patients we see, not by how well we see them. So it's a fee for service. And lack of knowledge. Or professionals don't have knowledge, and the patients also, they don't know what to expect from these pills. This is the Royal College of Physicians and Surgeons in Canada. They say that the opioid crisis is basically a problem of overprescribing because too many people complain with pain to the doctors, so doctors are prescribing a lot. Canada is the second user of opioids in the world. North America, we consume, between the United States and Canada, we consume 80% of all the opioids produced in the world. Okay, United States is the first and Canada is the second. And there's a huge problem among the First Nations. And the number of opioid deaths has just doubled in the last couple of years. So, tackling the opioid crisis. I copied this from Health Canada and I helped them to do, I went to the meeting on November 2016 where there were more than 50 organizations there to try to, okay, what are we doing for helping the opioid crisis? Here at Toronto Rehab, we are helping with prevention. We are doing something about treatment. I'm not going to talk about harm reduction and enforcement because we are doing very little here at Toronto Rehab. So what are we doing at Toronto Rehab in terms of prevention? So in the prevention stream, they say improving prescribing practices. And I'm passionate about this because I want every physician in Canada to know the guidelines, the recent guidelines. I want them to practice what the guideline says. I created this tool, and I want every physician in Canada to have this available to them. But many don't use paper, they use electronic medical records. We need to implement this to electronic medical records. I did an app, but only 5,000 people downloaded the app. How many physicians are in Canada? More than 30,000. What is, 5,000 downloads, and it's not enough. I need to do more. So we created an online, I and John Flannery, we created an online teaching module that anyone could take in Canada. This is online. Very few people are taking it. I need to get the word out. I need to educate my colleagues to do the right thing. The other stream of prevention is also, they say, better inform Canadians about the risks of opioids. I want every Canadian who uses opioid to know about that one slide that you saw here. I did My Opioid Manager, this book that you have here in your table. It's free to download. You can go to the website and download the PDF. I tell the doctors, my friends, download the book, give to your patients, explain to them, but they don't have time, they don't know, they don't think it's important. I think patients need to be informed about the risks. I did an app. The app, My Opioid Manager, is free for the patients. They can download and use it. But we need the word out. We also need to update, the content of the My Opioid Manager, because when I wrote in 2013, we were based on the evidence up to there. Since 2013, a lot of things have come up, so I need to update the content of the My Opioid Manager. We are doing ECHO here. We are funded by the Ministry of Health to educate physicians in Ontario. So this is a session of ECHO. What is ECHO? That's the project that Dr. Flannery mentioned, the hepatitis C in New Mexico. We went there, we learned how to do ECHO, we brought to Canada. This is my interprofessional multidisciplinary team. We have 12 professions sitting. The room is on this floor, second floor. This is the room there. And every week, we are there, 12 professions sitting around this table, and we are connecting to anyone in Ontario, any healthcare professional, doctors, family doctors, pharmacists, nurse practitioners, physician assistants, physiotherapists, occupational therapists. They register to ECHO. They come up on this screen. We are there every week for 2 hours, every Thursday, 12:30 to 2:30, and they present their cases to us. So when they present their cases to us, we will tell them, these are our recommendations, this is how we would recommend you to do with the opioid. Maybe the opioid dose is too high. This is how you would come down on this dose of the opioid. And when one person is presenting the case, everybody else is listening and learning. So we are moving the knowledge to rural, underserved, remote Ontario without having to bring the patient here to be seen by us. And then we are improving capacity because once they learn with one patient, they are able to do that, apply that knowledge to so many other patients. We have done some special sessions in the ECHO. We did some in the evening. We did the first evening session in December 2016. We had 50 people registered. And then in March, 100 people registered. In July, 150. That was a big, imagine that screen. We had 5 or 6 screens with 30 people in each one. There were a lot of pharmacists attending in July, and this was some evening sessions that we had about opioid de-prescribing, how to de-prescribe. So patients like Kirk, who went through hell just because he had to de-prescribe himself without help from his doctor because his doctor did not know how to help him. And it took, 7 months, Kirk, for you to come off the opioids? And if, you don't want your patients to suffer the same thing. We teach now these doctors, nurse practitioners, pharmacists, how they can help their patients so they can lower the dose of the opioids without having to suffer a lot of withdrawals. So the other component of tackling the opioid crisis is in the treatment. So the Health Canada says we need to improve treatment options for pain management, and that's exactly what Dr. Dinesh Kumbhari is trying to do with the myofascial pain syndrome, because muscle pain comes in almost, every patient. They may have a nerve pain plus muscle pain. They have an osteoarthritis plus muscle pain, myofascial pain, and that's a type of pain that we can help them and treat. So that's so important. We are also happy to say here that with funding from Game Ready, we are going to do randomized trials for people who have knee and joint and hip replacements to lower their opioid use here in hospital so they can be discharged from hospital with no opioids or very few opioids by using a device that applies ice and compression. Because why do we need to prescribe opioids if we can do this with ice and compression? Right? And our patients are being discharged with a bag full of opioids to take it home. We're also using Driver Lab here in the basement of this hospital. That we have a driving simulator. If you didn't have a chance to see it yet, talk to Giovanna, and she can organize a tour for you. But Driver Lab is a car simulator that we are using here to test our patients on opioids, other medications that may affect their cognition. And I am the coordinating editor for the Cochrane Collaboration Back and Neck Group, where we do systematic reviews, meta-analysis, Cochrane reviews for treatments of interventions for back and neck pain. So I am the author of the Cochrane review of acupuncture for back pain, massage for back pain. We need to review the randomized trials. We need to include this in Cochrane reviews so then we can have more evidence to show that other things, not just opioids, but other things work for treatment, especially for back pain and neck pain. Opioid crisis is very complex. It's not a simple thing. So what we have achieved so far? I did the opioid manager. I did the My Opioid Manager. We have the Driver Lab here, and we got a seed grant from the J.P. Bickle Foundation to study some of the opioids. But I need to digitalize the Opioid Manager. I need to update the My Opioid Manager. We need to use Driver Lab not just for the short-acting opioids that we had the grant to do, but we need to do what happens if people are using opioids and antidepressants. Can they drive? Can they work? What if they're using, a lot of my patients now come and they're using cannabis, medical marijuana. I prescribe cannabinoids, especially the synthetic ones and the oils, especially helping people to come off of the opioids. I use the synthetic cannabinoids and then I remove the synthetic cannabinoids. We have to try to reduce the amount of medications, and we need evidence. So using the Cochrane reviews, also that will help us to make this evidence. Once you have a Cochrane review, a meta-analysis, then they are included in guidelines, and once they're included in guidelines, people start talking about them. So here we are doing basic science with Dinesh, we're doing discovery, we're doing innovation in the pain area. We're doing pain management. We see lots of patients with pain. We're doing training of fellows, training of students. We have fellowships for our international. We have fellows from Singapore right now. We have fellows from India, Colombia, who come here to learn about chronic pain, what we do here. We're doing patient and public education. We have groups here at Toronto Rehab that teach patients self-management. And we're doing physician education with the tools that we have developed, and with the ECHO, we are doing telementoring. We would like to put all of this together in a pain college, bringing all of this together under one umbrella, that where people would go and see what they need, and this is what I need. I'm a physician, so I can grab this information. I'm a patient, I can grab this information. This is my Twitter account, and I like to say that this is how I define myself. I'm a physician trying to improve the person that has chronic pain, when everyone else tried to improve the pain that my patient had. Thank you very much. I think that's back to you.
Thank you, Andrea, for the presentation. We now have time for, so she had a great wish list. We really think that, the direction that she's taken and the direction that we're taking at our musculoskeletal program will enable us to move forward and actually make some of these changes occur to deal with a crisis that's right in front of us, but also just to help people move and function as we age. And guess what? We're all aging. Haven't figured that one out. We're not going to have that one figured out for a little bit of time yet. But we can help us function well, which is the whole premise of rehab and physiatry.